Okay, can everybody please take a seat? Okay. Well, it's my distinct pleasure to introduce our next keynote speaker. The person I'm introducing is, of course, Jill First. Jill is professor in the Department of Otolaryngology and director of the Cochlear Implant Program at Washington University in St. Louis. She's also an adjunct professor in the program in Audiology and Communication Sciences at CID at WashU. Jill was a clinical audiologist for 8 years during the very early days of cochlear implants, participating in the Nucleus 22 multi-channel clinical trial in adults in 1985, as well as the pediatric trial in 1987. This clinical experience fueled her desire to pursue a PhD, which she completed in 1998 at the University of Illinois, with a portion of her studies being at Northwestern under the tutelage of Nina Kraus. Over her 40-year career, she's directed 3 cochlear implant programs, one at the Carle Clinic in Champaign, another at the Medical College of Wisconsin in Milwaukee, and then currently at WashU, where she's been for the last 19 years. Jill's career and clinical experience informed her research career, which has been funded by the NIH for over 25 consecutive years now. 2 of those NIH grants were FDA-approved multi-center clinical trials studying outcomes first in adults with asymmetric hearing loss, and then most recently in children with single-sided deafness. An additional goal of these 2 studies has been to determine whether evidence exists to support expansion of candidacy criteria for cochlear implantation. So throughout Jill's career, she's emphasized the value of clinical and research interactions, using clinical experience to ask relevant research questions, and also using research findings to guide clinical care of patients. A single patient sparked Jill's interest in the asymmetric hearing loss, which she'll talk with us about today. So let's welcome Jill to the podium.
Okay, can everybody hear me all right? Okay, good. I can't see you at all, but okay. These are my disclosures. And I'd like to start by talking about this individual subject, S11. This is a person who was in my doctoral dissertation a number of years ago, and she had a very interesting hearing history. So she had normal hearing until the age of 7, at which time she got the mumps, and that left her with a profound hearing loss in one ear. She had that hearing loss for 40 years, and then at the age of 47, she acquired an acoustic neuroma on her good ear. So the neuroma was removed, and that left her with a profound hearing loss in that ear. That would have been the ideal ear to implant. However, when the tumor was removed, the auditory nerve was severed, and so that ear was not a candidate for a cochlear implant. So 1 month later, she got an implant in the left ear, the ear without any direct peripheral stimulation for 40 years. So she was in my dissertation, and I was also working with her as a clinical audiologist, and we talked about expectations and what she might get from an implant. And given the times and her very unusual hearing history, I really wasn't sure how she would do with an implant. So these are some speech recognition results. The top panel are word and sentences in quiet, and the bottom are word and sentences in noise. And she's S11. And after just 3 months with a cochlear implant, she had open set speech understanding in that ear for both a quiet and the start of speech perception in noise. And she went on to do very well with the cochlear implant. So I thought about her for quite a long time, and I wondered, did having normal hearing in one ear help to maintain the opposite ear for a good outcome? Was it having hearing in both ears until the age of 7 and establishing binaural pathways the main reason? And how should we think about length of deafness? Again, at that time, we were used to working with patients with bilateral deafness. So this was a case of unilateral deafness for 40 years. And this particular subject was the main reason that I became interested in asymmetric hearing. So we should never underestimate the importance or the value of a really interesting patient or the outlier in your data to really make you think about the auditory system. So this led to a number of research questions looking at the effects of asymmetric hearing. And we were interested in speech recognition and noise and localization. These are two areas that people with asymmetric hearing have a lot of difficulty. We were interested in self-assessment of perceived hearing abilities. So how do individuals with these hearing losses feel that they do in everyday listening environments? Do they struggle, or do they feel that they get along okay? And we were interested in quality of life and cortical organization. We know that we hear with our brains and not just our ears. And so what happens when the brain only receives input from one side? And then we were also interested in these demographic variables that affect outcomes, and in particular, age at onset of deafness and length of deafness. This also led to clinical questions. Should current candidacy guidelines be modified to include asymmetric hearing loss? Guidelines at the time were for bilateral deafness as far as cochlear implants, not when one ear was deaf and one ear had better hearing. And historically, guidelines have not considered treatment of each ear separately. We also talked about what measures should we use to document deficits pre-implant and benefits post-implant in this population, and then what expectations do we have for outcomes in these cases. So this led to a progression of studies in asymmetric hearing loss in adults and children, and then also unilateral hearing loss or single-sided deafness, and I'm going to use those terms interchangeably. So I'd like to define for you what I mean by those terms. For our work, asymmetric hearing loss refers to one ear that meets CI candidacy and one ear does not. That ear has too much hearing for a cochlear implant, but not normal hearing, and usually is using a hearing aid. So once the poor ear is implanted, then bimodal hearing refers to a hearing aid in one ear plus a cochlear implant in the other ear. Then for UHL or SSD, one ear again meets CI candidacy, and one ear has normal hearing. So once implanted, then bimodal hearing refers to normal hearing in one ear plus the cochlear implant in the other ear. So we published this article in 2008 in JRRD. This was at the request of Harry Levitt from City University of New York. And it was titled Restoring Hearing Symmetry with 2 Cochlear Implants or 1 Cochlear Implant and a Contralateral Hearing Aid. And these are some sentences from the article. Persons who have only one ear with severe to profound hearing loss and the other ear with more hearing have not been considered cochlear implant candidates. So this was the status of the time in 2008. So this led to a number of areas of study in asymmetric hearing. So we started looking at realistic and effective test materials. We were looking at different populations who had hearing asymmetry. So that can be created by having one cochlear implant and then later getting a second side. Also asymmetric hearing and getting a cochlear implant, or single-sided deafness and getting an implant. So I'm not going to talk about all these studies today, but what I'm going to do is just pull a few highlights from some of these studies to describe the journey that we went down. So I'd like to start with this study of adults with asymmetric hearing who received a cochlear implant in the poor ear. And especially I want to talk about postlingual versus prelingual onset. So we had a few individuals with prelingual onset of hearing. You can see in red, this was their ages of onset, which was very young. Also, for the most part, they had never used a hearing aid in the poor ear, and they had long duration of deafness. What I'm showing you here, these are CNC word scores through the cochlear implant ear alone after 6 months experience. And all of these data, all of these bars are for postlingual participants, and these were our 4 prelinguals. You can see that some of the postlinguals had some hearing aid use in the poor ear before they got an implant, and some had never used a hearing aid in the poor ear. And all of these postlinguals, regardless of having used a hearing aid, have a blue bar. They all have some open-set speech understanding compared to our 4 prelinguals who have very little. And that's despite some of the postlinguals having 32, 34, 40 years of deafness compared to our prelingual participants. And that's also despite the fact that the prelinguals had substantial hearing with a hearing aid in the opposite ear. So these outcomes really pointed to us the strong effects of age at onset. We were also starting to study children, and we worked with some adolescents with asymmetric hearing loss. These data were available in 2013. And again, we had a couple of children, P4 and P5, with onset from birth. They had never used a hearing aid in the poor ear, and they were also implanted later as teenagers. And we see from here, these are CNC words in quiet on the left and in noise on the right. This is P4 and P5. They have 0 open-set speech understanding through their CI ear alone for quiet or noise. And they also don't have this brown bimodal bar. So this bar reflects bimodal hearing where they're using the 2 ears together and demonstrates benefit over just listening with 1 ear alone. And they did not have show any of those bimodal benefit effects. So again, that pointed to the strong effect of age at onset as well as age at implant for children. We were also asking, how do adults with asymmetric hearing perceive their hearing and communication abilities? Do they struggle in real-life listening situations, or do they feel that they don't struggle? And in this particular study, we had 4 groups. The first 3 groups all had hearing loss, and they all had 1 deaf ear. So 1 deaf ear with no device. Then in the opposite ear, the hearing varied. So we had a UHL group that had normal hearing in 1 ear. We had a cochlear implant group with a cochlear implant in 1 ear, a hearing aid group with a hearing aid in 1 ear, and then we had a group who had normal hearing in both ears. And the results of looking at the SSQ, so the speech, spatial, and qualities of hearing scale, and getting all the feedback on all of those listening questions from the participants showed us that the 3 groups with 1 deaf ear were not different in their own perceived hearing disability for 6 of the 10 subscales. So these 6 subscales that you see, there were no differences between those groups. In other words, normal hearing in 1 ear was as disabling as listening with a unilateral implant or a unilateral hearing aid. And we were a little surprised by this. We thought we would see more differences amongst the group with 1 deaf ear, and especially the normal hearing UHL group. So we also asked, how do parents rate the abilities of their children with unilateral hearing loss when listening in everyday situations? Do parents feel that their children struggle or not? And again, using the pediatric version of the SSQ, here the rating on the y-axis, 10 is a very high rating, so my child does not have any difficulty, and 0 is a low rating, my child has a lot of trouble. And the blue is normal hearing children, and the green is our UHL children. And so you can see from the parent ratings that they rate their children's abilities much lower than children who have normal hearing in both ears. So quantifying these abilities really helped us as clinicians, as researchers, to understand the severity of the problem in real life, not just in our test booth or in the lab, and also the patient's viewpoint for both adults and children. So we went on to study more adults who were getting cochlear implants who had asymmetric hearing. And this work was published in 2018, and by that time, the hearing in the better ear was getting better and better for people with asymmetric hearing loss. So I also would like to acknowledge not only WashU, who worked on this study, but also Midwest Ear Institute in Kansas City. So we had 47 adults who were in the study. They had asymmetric hearing loss. They were all implanted in the poor ear, and they had varied hearing in the better ear. So we had this group 1 who had a PTA between 0 and 40, and the mean was 23. So they were really more like an SSD group or a few people with mild hearing loss. We had group 2 where the PTA was 41 to 55, so in the moderate range, and then group 3 with a PTA in the moderately severe range. So here what I'm showing you, this is looking at bimodal benefit for each of the groups. So we have group 1, group 2, and group 3. And these are timid sentences and quiet and timid sentences and noise. The timid sentences are harder sentences than the AZ Bio sentences. They have multiple talkers, varied dialects, and so forth. And for each group, there are 3 bars. So the middle bar is the bilateral or bimodal condition, and then the orange bar is the better ear alone with a hearing aid or the CI ear alone. And you can see for groups 2 and groups 3 that they all have this bimodal benefit. The red bar is higher than the other 2 bars. And we see that for quiet and we see it for noise. Group 1, however, looks different. So the bilateral bar is not higher than the orange bar, the better ear. And you also see that the better ear performs much higher than the better ear of groups 2 and group 3. When we look at localization, however, we see a different pattern. So this is RMS error, lower is better. The red is the bilateral or bimodal bar. And so if they have benefit, that bar will be lower than the other 2. And so you can see that all 3 groups show the same pattern for localization, and they all have bimodal benefit with using a CI. We were also interested in what does the implant ear alone look like across these groups. So this is back to timids and quiet, and the implant ear alone is in yellow. And you can see that the performance looks pretty similar across the groups. The same was true essentially for noise and actually all of our measures. When we look at localization, we see also the implant ear alone looks about the same. And when we look at CNC words, we see the same thing, that the implant ear looks similar. So the CI performance was similar across those 3 groups. So just a couple points here. The groups with less hearing had greater bimodal benefit. But bimodal and better ear results were different for group 1 versus groups 2 and 3. So for future studies, we thought we could combine groups 2 and 3, but we should keep group 1 separate. So we went on to study more adults with asymmetric hearing loss, and especially focusing on groups 2 and 3, and this was a multi-center clinical trial. We published our first paper last year. I'd like to acknowledge all 4 sites, so Washington University, Midwest Ear Institute, House Ear Clinic, and NYU in New York City. This was a prospective clinical trial. It was approved by the FDA. The inclusion criteria were broader than the approved candidacy criteria. It was funded by the NIH, and it was approved by Medicare. So these are the criteria for the poor ear to be implanted. Our criteria are in black, and the FDA criteria are in red. And so you can see our PTA was at 70 dB and greater. Our aided word score was less than 30%. Our duration of deafness had no upper limit, whereas the FDA has a indication that the hearing loss should not be longer than 10 years. And then for the better ear, the PTA was between 40 and 70. So again, we were looking at groups 2 and group 3. So the summary of our broader candidacy criteria was a lower PTA, a higher word score, and no limit for length of deafness. We had a number of test measures and conditions. I'm going to talk about a few of those. And we had several questionnaires, and so we are analyzing these data at this time. We had 40 adults who were implanted across the 4 sites. The mean age of implant was 69 years, but we had a wide range from 45 to 84. The mean length of deafness was 10 years, but we had a range from as short as 1 to as long as 45 years, and we followed them through 1 year post-implant. This is a table looking at just the poor ear before and after getting an implant. So these are the 3 measures we looked at: audibility, CNC words, and AZ-Bio sentences. These are pre-implant scores and then out through 12 months. And so you can see the significant improvement in their word understanding for words and sentences, and also you see the lowering of their thresholds for audibility. We were also interested in the poor ear outcomes over time. So we looked at audibility, CNC words, and AZ-Bio sentences. We used an HLM analysis, a hierarchical linear model analysis, to predict performance. And so what you see on the x-axis are time in days since pre-implant. Pre-implant is shown in green, and then our other intervals for 3, 6, and 12 months are shown in the different colors. This horizontal line represents the first significant change in performance from pre-implant, and the dashed line represents when the performance starts to plateau. So for all of our measures, we see this improvement over time, and you also see that the significant change happens way earlier than 3 months, which is in blue, and you also see the plateau happens a little bit after 6 months, and that was true for all of our measures. We also wanted to look at the effects of age. So again, looking at the poor ear and using our HLM analysis. Again, we have time, days since pre-implant. The mean age for the group was 69 years, and so 1 standard deviation below was 59, which was our younger participants, and 1 standard deviation above was 79, which was our older participants. The younger are shown in green, and the older are shown in blue. And we had a significant effect for age for the sentence material. So you can see that the younger did better than the older. You also see that compared to pre-implant, both groups show substantial improvement with an implant. So we had an age effect for sentences, but no age effects for audibility or for CNC words. We also wanted to look at length of deafness, and again, with our same analysis, we used a division of 10 years because that's the FDA criteria. So in orange, the orange line is deafness less than 10 years, and the purple line is deafness greater than 10 years. And again, we had an effect for length of deafness. Those with shorter length of deafness did better than those with longer length of deafness. But you also see we have substantial improvement with both groups or both participants where they are much better post-implant than pre-implant. So just to summarize a couple points here, for effects of age for sentences, younger did better than older, but there was no age effect for CNC words or audibility. So this supports using CNC words for candidacy rather than using sentences. The outcomes were better when length of deafness was shorter, but both groups benefit. So this supports not restricting length of deafness. We also looked at the FDA criteria for PTA and CNC, and so you see these criteria here that are in red. We had 16 people who met that criteria and 24 people who did not. And our analysis showed that meeting the FDA criteria did not moderate the outcomes for any measure. Both groups showed similar benefit. And then finally, we wanted to look at a couple of other ear conditions. So these are all of our measures. The red line is the better ear by itself, so we wanted to see what happens to the better ear alone over time. So the red line is relatively flat from pre-implant to 12 months post-implant, and you see that flat line essentially for all of our measures. So the better ear was stable. Then we wanted to look at just pre-implant, how does the better ear compare to putting a hearing aid in the poor ear? And so for all of our measures and testing, we did that. And for 4 of the measures, you see that the red data and the blue data overlap. So there's no benefit to put a hearing aid in the poor ear pre-implant for those measures. However, we had 3 measures where pre-implant, you can see there's a separation in those data points. These measures, the scale lower is better, and so you can see the blue data point is lower than the red data point. So they actually benefited by having a hearing aid in the poor ear pre-implant for localization and quiet, localization and noise, and speech and noise when noise was directed to the better ear. And then finally, we wanted to look at better ear versus bimodal. So now we're looking at just the post-implant phase here from 3 months to 12 months, and we're comparing the red line to the blue line. And the blue line is higher across all of the test intervals for all of the measures except this one. And so what that means is by adding a cochlear implant, their performance is significantly better compared to just using the better ear by itself. So our overall recommendations for changes to candidacy include a 3-frequency PTA in the poor ear greater than 70, CNC word scores less than 40%, length of deafness 10 years should not be an exclusion, and age should not be restricted. We were also studying adults with single-sided deafness, so the adults in group 1. And I just want to make a couple points about that group. So these were 23 adults who met these criteria for group 1 with a PTA mean of 19. And what I'm showing you here, again, is the poor ear CNC word scores through the cochlear implant after 6 months experience. So this is P1 all the way through P23. And these are CNC word scores. And you can see there's a wide range. We have people down at 10%, and we have people up at 90%. And even when we rank them by length of deafness, so shortest length of deafness to longest, and even looking at these people who all have length of deafness less than 10 years, we see no real strong pattern. So there's a lot of variability amongst the SSD, even when we reduce the deafness to less than 10 years. And so what are the reasons for that? Is it related to the implant ear alone and something peripheral? Is it related to the bimodal condition? Because we know there's a big discrepancy in frequency and loudness between an implant ear and a normal hearing ear. Or is it something cognitive? There's interference by the brain when you're using these 2 very different signals together. So we've been working on these latter 2 points. And we have 2 new studies, one looking at the effects of interoral pitch and loudness mismatch, and one looking at the effects of SSD on the brain and behavioral outcomes. And we have completed our data collection, and we're analyzing those data right now. So the last study I want to talk about is in children with single-sided deafness, and this is also a multi-center clinical trial. I'd like to acknowledge all 5 teams: Washington University, Children's Hospital of Philadelphia, USC, Hearts for Hearing in Oklahoma, and the University of Minnesota. Again, this is a prospective clinical trial approved by the FDA, funded by the NIH. There are 2 phases to the trial. There's a hearing aid phase where there are 5 hearing aid visits spaced 3 to 4 weeks apart. And the children are evaluated with a hearing aid in the poor ear for candidacy. And then most of the children are fit with a cross aid for the hearing aid phase. And then we follow them through 15 months post-implant. The youngest age to be in the study is age 4, and the oldest is 14 years, 11 months. And you can see the FDA criteria starts at age 5, so we were going 1 year below that. These are our criteria for the poor ear. Again, our criteria in black and the FDA criteria in red. So we have a PTA greater than 70, a CNC word score less than 40%, duration of deafness maximum 10 years. As far as age at onset, if the child is 4 or 5 years of age, the loss can be congenital. But if they are older than 5 years, 11 months, we want to see evidence of a non-congenital onset. So the summary of our broader criteria is a lower PTA, a higher word score, and a lower age. And these are the inclusion criteria for the better ear. We have a number of test measures. I'll talk about a couple of them. And we also have a number of quality of life questionnaires, and I think we're going to learn a lot from the parents and the children on these questionnaires. This is our status. We have 28 children enrolled, 24 have finished the hearing aid phase, 23 have had surgery and been activated, and then you can see the various numbers post-implant. I just want to mention a couple things about the hearing aid phase. So as far as using a hearing aid prior to enrolling in our study, half of the participants had never used a hearing aid in the poor ear, and just a few of them had used a hearing aid for 1 or 2 months. And then about 1/3 were using a device at the time of enrollment. Another thing I want to mention is that 4 children completed the entire hearing aid phase and then decided not to get a cochlear implant. And these are showing you pediatric SSQ results. Again, the rating is 10, I don't have any difficulty, and 0, I have a lot of difficulty. And what you're seeing are the gray box plots are the children who went on to get a cochlear implant, and the 4 colored symbols are the children who did the hearing aid phase and then withdrew. And so you can see there is a spread of scores in the spatial section, but otherwise the ratings by the parents are relatively high. So parent ratings may be helpful in determining candidacy, and a hearing aid trial may be appropriate for some children. Now I want to show you a couple slides of results of children who went on to get a cochlear implant. This is our speech and noise task. So this is SRT, and lower is better. What you're looking at in blue are the results from the hearing aid phase, and then in yellow is when they've had a cochlear implant for 3 months. And so you can see that when noise is from the front, we don't see an improvement by having an implant. And when noise is to the better ear, we also do not see an improvement. Where we see a significant improvement is when noise is directed to the poor ear. So the SRT is lower or better with an implant at 3 months than with a hearing aid. We're looking at localization. These are individual scores for children, and the blue is pre-op, and the orange is 9 months post-op. And then again, this is RMS error, so lower is better. And we see that for 8 of these children, the orange bar is substantially below the blue bar. So we see localization improvement for 8 of the 12. We're looking at data logging, so hours of device use during the hearing aid phase and then the CI phase. And you can see that at 3 months and 6 months post-implant, there's a large improvement in their usage, but you also see a lot of variability. And I'm showing you that variability here. So these are all individual children with different colored lines. This is 3, 6, 9, and 12 months post-implant, hours of device use. And you can see that at the end of each line, there's a number, and that's their CNC word score after 12 months. So all of these children have pretty good device usage, and they all have some open set speech understanding. And then we have 4 children who do not. 3 of the 4 had a few hours of device usage, but that has gone down over time. So that is very concerning to us, and we are keeping an eye on this. So we have a multi-center clinical trial underway. The benefits include some of what I showed you. There is considerable variability, and our data collection is ongoing. So I just have a couple slides to end with that I wanted to talk about what I see as gaps in knowledge and needs in our field. We need a greater understanding of variability in SSD. I also want to mention that clinical practice moves faster than research studies. Patients seek help, and that creates a gap between clinical care and the time it takes to develop, fund, and execute studies. And that leaves us as clinicians to rely on our experience because research results are not available. So I would love to see that gap be shortened. We also need added support as far as funding and resources related to diversity so that we can better represent all of our patients and their outcomes. Non-use of CI. This has occurred as the field has evolved. We saw this with early cochlear implants in the late 80s and early 90s. We saw it with sequential implants with children who were getting a second side later. Are we seeing it with SSD? I think it's inconclusive, but this is something we need to watch. Age at onset of SSD in children can be difficult to pinpoint. So I think that our data and what we're looking at with our participants is that we need an added hearing screening between the newborn screening at birth and the screening at kindergarten. We know these are very important years for auditory development. And we need more studies of oral rehab for SSD. Do patients need more concentrated time with the implant ear alone, or how can we facilitate greater interaction between the normal hearing ear and the CI ear? And then my last slide is that I still believe we need to treat each ear separately, that CI candidacy for the poor ear should be similar regardless of the hearing in the opposite ear. The current criteria are more restrictive in the poor ear for SSD than for traditional candidates who have bilateral hearing loss, and I hope our continued evidence will support changes to candidacy. So I'd like to acknowledge all of our funding sources, thank our participants for their time, thank our colleagues and collaborators, and I very much thank the ACIA for the opportunity to give a keynote lecture at this conference. So thank you so much. I think we're moving into a panel. Okay.